Well, it's a total pleasure to be here and a real privilege. Anytime Peter and Mandy call and offer a chance to visit beautiful England, I always say yes if I can. And this is a real honor and something I'm very proud of. So we're going to take a little journey together for the next 35 or 40 minutes. And it's a journey that I started actually when I left being the chairman of my Department of Biostatistics. And for a period of my career, I set aside the day-to-day detailed research that I had done most of my career, and I became a university administrator. In the end, as I look back, it wasn't the best move in my career, but I did make it back to the bench alive and well, and with a certain perspective about what's happening in the field of public health and medicine in particular. My university, Johns Hopkins, is 80% about the human health. 80 out of every 100 faculty work on problems of human health. And so when there is a transition time in the field of medicine or public health, my university feels it acutely. And as the person responsible for research at my university, I became aware of very dramatic changes in the field. And I want to just tell you about what's happening. You have the same experience here. You're a much more mature country than America with respect to healthcare and public health. But let me tell you what's happening at the United States. And let me tell you why that is now an opportunity, as in many other fields, for data scientists, and in particular statisticians, to play a much larger role in public health and medicine. And in particular, I would say that medicine, which was traditionally a biologically based profession, is now equivalently bio and data science based. And there's an enormous transition underway. So let's talk about that. The transition is really led by the kinds of things you can see in this picture. A DNA sequence, an annotated image of a brain, pictures of people's telomeres, indicators of the age of their genome, of their DNA, and then longitudinal measures of a biomarker. That's the kind of data that's now routinely available on people who are either healthy or people who are diseased. And the health system is now in a position to need to use this information to make better choices about the state of health, the trajectory of health, and the likely interventions that will improve health. So it's with that context that I want to talk to you about so-called individualized health or stratified medicine. But there's one other thing I have to tell you before we get started in the statistical part of this, and that really is, some people call these data big data, and it's an overused term, but anyway, I'm going to just focus on a big datum. And it's this datum, it's the length of that red line. Now what I'm showing you is a picture of the per capita expenditures on health care for each of the 34 OECD countries over several decades. England is actually in the lower half of those curves, but America, liking always to be number one, is the very top dark curve. And if you figured out the amount of money that's represented by the American value, and it's about 2011, I think, and the second most expensive country in the world, anybody want to guess who that is? There was somebody who mentioned it just at the last session. Finland. It wasn't Finland, it's close, it's Norway. They didn't mention Norway, but it was close to Finland. And Norway's, and if somehow America could transform itself into Norway, the second most expensive country per capita in the world, we would spend $1 trillion less per year on healthcare. $1 trillion. That's 6% of the GDP of the United States. It's 25% of the GDP of England, right? We would spend $1 trillion less, and that's a big datum. Yeah? So when someone wants to know what big datum are, $1 trillion per year of wasted money in the American, not like over a decade, over per year, $1 trillion of waste. So this is actually not sustainable. You know, we don't build bridges, we don't build highways, we don't build railroad systems, we don't build education because we're putting the money in places where it's not doing any good. And I have a slide that shows the same data for life expectancy, infant mortality, any other things you want to know, and we're in the bottom half of that distribution, not in fact, near the bottom of the OECD countries. So this is the most pressing problem for America today. Right? So on the one hand, bioscience is generating new kinds of data that allow us to think differently about medicine, and on the other hand, the American healthcare system is taking the country in very negative directions. It's depleting the country of its infrastructure. So the question is, how does America deal with this potential catastrophe? Now, if this were Britain, and we were in this situation, you'd pass some law, the people, there'd be a big argument, you'd pass some law, and you'd create some sort of system that would be a solution. In America, there's no conversation about solving this problem with the government. It's just not possible. We're going to be way down the road to self-destruction before anything could ever happen. So it's just not possible. So what's the solution that people are proposing? It's to commodify healthcare. It's to try to make healthcare like McDonald's hamburgers, to sort of have everybody get the same service no matter what their circumstance. So commodification of healthcare is the way it's trying to go. And where are we looking for our solution? We're looking to Silicon Valley, and I can tell you that Google and Facebook and Twitter and Microsoft and Apple, they're spending on the order of a quarter of their R&D to try to solve this problem. Actually, what they really want is to try to commodify healthcare. Okay, so that's the background. Now let me tell you that my university, which was founded, my medical part of my university was founded in 1870-something, was built on this notion that healthcare and medicine should be individualized from the very beginning. And here's a quote from around 18-something, early 1900s, from the son of an immigrant from Falmouth, not too far from here. I think, yeah, Falmouth is pretty close. And his father was a Navy person. His father passed up the chance to be on the HMS Beagle because his father was dying. But soon after that, he immigrated to Canada, and his son, William Osler, became the first physician of Johns Hopkins University in 1870-something. And he said back then, variability is the law of life. And as no two faces are the same, so no two individuals react alike and behave alike under the abnormal conditions that we know as disease. And there's a culture at my university that the physicians who come there, their culture is that they are free to see each individual as its own laboratory and to try to understand what makes this person unique and to treat them accordingly. It is just the culture. So the question is it possible to mine that culture, to not commodify, to treat everybody the same, but rather to use data science to try to distinguish people and to improve the care. So the rest of this talk is going to be about that problem. Now, there were some wonderful talks here today about stratified medicine. There's a lot of interesting work in this area. I'm going to try to take a bit more of a philosophic view and then show you two examples where we're doing it. So this won't be technical. So the way we have to get started is we have to, each of us, play doctor for a moment, because you have to think for a moment, what does it mean to be a clinician, right? So is everybody prepared to, a couple times I gave this talk, I had the person on one side be the doctor, the other person be the patient. We did a little diagnosis here, but we're just going to all be doctors, if you're all right with me. So here's the problem. Your patient comes to see you. It's a 43-year-old man. This man has no family history of a particular lethal disease. Think cancer if you want. Particular lethal disease. And because the person turned 43, they were supposed to go when they were 40, but they didn't. You sent them for a routine screening test for this lethal disease, and they tested positive for the disease. They tried to get an appointment with you. Took them, in America, it would take them 2 or 3 weeks. And their children know about this. They heard the husband and wife talking at the dinner table. There's a lot of anxiety in this family. This person is now sitting across the table from you. You're his clinician, and you need to now explain to him what's the situation. What is this man's state of health? You feel my pain, you feel his pain, and you're the information source. So what do? Right? What do? What you do is you remember medical school, right? And you remember, oh, this particular disease, this is not a very prevalent disease, and this particular screening test, this isn't a particularly specific screening test, and so the positive predicted value, given the data, what are the data? 43 years old, no family history, positive screen. Given that data on that individual patient, right, what do? You reference that patient against a population of otherwise similar people. And in fact, this is the population. There are 15 out of 1,000 people who actually were exactly in this man's situation, but only 15 of them had the particular disease. So what you would say to this patient of yours, relax. You say, well, relax. I mean, it's been 2.5 weeks since I tested positive for this life-threatening disease. Relax. You probably don't have that disease, right? Then why did you send me to get tested? I tested positive. You probably don't have it. In 1,000 people like you, only 1.5%, 15 of them actually have the disease, right? What did we just do? We were statisticians. We took, or maybe we were epidemiologists. We took a set of data about an individual, right? And we referenced that data against a population of otherwise similar people in order to inform the recommendations for the particular patient. I'm not going to go through the recommendations, but you get the point. Medicine is an empirical science. It takes individual data and it references the individual against a population of people as similar as possible. Now here's what's exciting about medicine today. You know, this is what we teach in Introduction to Public Health. The first course we do, we teach this table. But now the opportunity is to reference that man not just based upon the positive test, but based upon his genome, based upon an image, based upon telomere length, many other complicated things. And so the game now is to be able to create the statistical or computational analog of referencing that man against the population in a 2-by-2 table, right? Where all you have to do is look at a binary outcome, but to be able to do the same thing where the measurements we're now making on the individual are much more complex. We want to be able to make the analog of the 2-by-2 table where what we measure is more complex than just a single binary screen result. And as time goes on, we want to be able to take that complex data about that man and be able to compare him to a population that's as much like him as possible. We want a subset, we want to so-called stratify. The more we can stratify, the more we'll be able to tailor what we recommend to the particular person at hand. So that's basically the game we want to play, and now the question is, how are we going to play that game? So before I go on, this doesn't play so well here, but when I'm trying to make this sales pitch at my own university, because this has lots of implications about what we should be doing, they don't pay a lot of attention to me, but I was out at Stanford University recently, and this was a slide that I saw from the dean of the medical school there, and you see he wants to lead, Stanford's going to lead the biomedical revolution. You see they're going to have preeminent clinical care, they're going to have transformative biomedical platforms, and how are they going to do that? He said, on quote unquote, we're going to build the leading tree of medicine in the fertile ground of fundamental research and biomedical data science. So there it is. You know, there's from Stanford University is going to build the future of medicine on biomedical data science. So that's why I'm here to talk to you today. So the question we just asked about that man who had that test is, what was his state of health? Did he have that disease? Oh, by the way, those data were data for mammography screening for breast cancer for a 45-year-old woman with no family history. And by the way, that I don't know how it works here, but in America, 40 to 45-year-old women are screened all the time with no family history, and the angst and the biopsies that get generated are quite common. So that wasn't a made-up problem, that was a real problem. And that was a problem about what's the state of the person's health, right? But we also often want to know what's the trajectory of their health. Not just where are they now, but where are they headed? And then most importantly, we want to be able to say what particular intervention should we use for people like this who have that state of health and that health trajectory. And then ultimately we want to be able to ask questions about the systems that provide health care. Are we behaving in an optimal way? And can we take that trillions of dollars of waste and cut it down some? So now, there's another problem that we've solved brilliantly that's the same problem, which is landing an airplane safely. I'm particularly interested in this because I'm going to be flying on one tomorrow, and I'm going to be landing at this airport, BWI, and how does landing an airplane work? Think about it. Well, there's a state of the airplane at any moment in time, and we tend to track the state with radar systems, and I've shown here a picture of the radar systems around the airport where I'll be landing, and those radar systems ping off the airplane, and they figure out where they think the airplane is. Of course, they make the measurements with air. These black dots are the repeated observations over time as the plane is coming from the west. Often we go beyond the city and then come back and come around. And so that the black dots are the radar measurements of the location. And then what they do in radar systems is they do what they call Kalman filtering, which is just a sequential application of Bayes' rule, and they smooth the data, and that gives the red crosses. And I'm just showing you that the actual location of the airplane is the blue line. So by smoothing out the measurements of the airplane location, can come very close to it, and they can actually see not only the location at any moment of time, but the velocity and the acceleration. They can see the trajectory, and then occasionally they pass a little instruction over to the pilot, and they say, turn this way or turn that way, and the pilot, unlike a patient, does exactly what he or she is told. And lo and behold, time after time, it's amazing, time after time lands safely at the intended location. So think of this as an analogy for the patient. What we really want to do is we're making measurements of the patient over time. We need to smooth those measurements somehow, and that's what this talk is about, how to do that smoothing. And then we need to give instructions here and there, hopefully get patients to pay attention to the instructions, and then land safely at the end of life with a compressed set of morbidity and on to the next thing, whatever's next. So now, the question I have for you is what's different about airplanes and patients, besides the fact that patients don't listen as well? What's different? What's the big difference?
Metal and other such stuff.
Metal. Well, what's the point? Yes, it's physics rather than biology. And in fact, there are laws of physics which govern this problem. And in fact, they don't have empirical assessments of the errors in their measurements. They do have those, but those are long ago determined. They're characteristics of the radar system, and they have the laws of physics to figure out, given that you're here today and given this, where you're going to be in the next few minutes of time. The laws of physics are a big game changer that make this problem different than the one you and I are talking about now. So there are two things that are going to happen in medicine, and they're complementary to each other. The first thing is we're going to be discovering all this new data. It's not here yet, but slowly and surely we're starting to discover some aspects of the disease processes. We'll come to understand the mechanisms of disease better, and probably probably sooner, we'll be getting even more new measurements of the underlying processes that govern health and disease. So that's going to be it, and that'll make us more like the airplane problem, right? So we'll have some of the laws like we have in the airplane. But the other thing, and let me just give one quick example of that. This is one that just happened recently at my institution. This Jun Lo is the senior author on this paper. This is a discovery made about men with end-stage prostate cancer. It turns out there are two treatments which have been demonstrated to be effective. There's sort of a form of chemical. They basically suppress testosterone, which is a problem at the end of the prostate cancer. And there are two drugs that cost in total in the United States about $2 billion per year. That's how much we spend on them, $2 billion per year. And it turns out these drugs have no possibility of working for half the population. Half the population of men who have disease have a particular RNA receptor that these drugs cannot do anything for. And it costs $100 to measure what kind of receptor you have, this ARV7 receptor. Cost $100, we can now measure it, and we do measure it, and so we can say to half the men who would have been treated that each man's course of therapy is at least 3 months and cost about $35,000. We can say to them, this treatment will not work for you based upon a $100 test. So that's an example of a discovery that's a new measurement that allows us to understand the mechanisms of disease. It makes us like the airplane. But let's go on to the more common way in which we operate, which is to try to take the existing science and the measurements that we currently have and to try to use them more intelligently. And really what I'm going to do is propose to you that a lot of what was discovered here in England, Bayesian graphical models, is the way forward. And what we've been trying to do in my group recently is to try to build examples where, by more carefully looking at the data that's already available, we can improve the quality of care. We can not do things that won't add value and do those things that will add value. And that's the way forward to kill that $1 trillion of waste. We have to put in front of clinicians better evidence about what they can and cannot do to improve patient health. So let me now take you through the ideas of this Bayesian model, and I'm just going to show you some Greek notation because it's not a statistics talk without a little bit of Greek, but each thing is quite a simple idea. I'm just going to show you a particular graphical model that we're going to then use a couple of times to illustrate what I'm talking about. So remember I said what we want to know is the state of health, we want to know the trajectory of health, and we want to know what treatments do to that trajectory. So let's just build a little model that has those components. So here we are. Eta is going to be the true state of health. It's like whether that man had that lethal disease or not, right? So eta, and it can change over time. It can have a trajectory, okay? I'm going to use discrete time to make this simple, and I'm going to actually have an indicator variable, delta, which is going to say you might be in a rapid progressing subgroup or a slower progressing subgroup. It's just going to be an indicator of the nature of the trajectory, okay? So everybody with me? This is the true state of health. We wish we knew this. If some higher being would whisper this to each clinician, we'd be set. We wouldn't waste as much money. We'd know what were the optimal treatments. Let's see if we can move in that direction. So then the idea is to just say that state of health, which changes over time, it's affected both by covariates, like factors about the person that are so-called exogenous outside of the treatment system, but then also by treatments. So you can give, there's sort of covariates that are exogenous and covariates which can affect the state of health, which are endogenous, as you'll see in just a minute. So I just have predictor variables which are going to change the state of health. And the most important among them are the treatments. Are you with me? And these regression coefficients, and notice this is the regression coefficient for person I, right? This is just saying how the treatments will affect the state of health. Anybody object to this so far? Keep going? All right. So then we can only make progress if we can get imprecise or even precise measures of the state of health. So these ovals are unobserved. The blocks are observed. We observe the treatments and the covariates, and now we observe at some of the times the state of health. So think of that like the screening outcome, right? And there's a characterization of the measurement process. These parameters tell us how these measurements relate to the underlying state of health. So this is a framework. It's a simple model, but this is actually how clinicians think. They know that there's some state of health. They know that their measurements are reflecting that health. Often they forget that the measurements aren't the thing itself. They tend to treat the measurements rather than the underlying state of health. But in America, there are incentives to do that. If the measurements go a certain way, you can charge dollars, and everybody does it. And then the question is, how do these covariates and these treatments affect the state of health? Okay, so the interesting part of this problem is it's based upon the past measurements that the clinicians then make decisions to change the treatments or to impose the treatments. And there's actually a nice aspect to the fact that it's the measurements themselves, not the state of health, which tend to drive the treatment decisions. And that actually gives statisticians some power to be able to do something useful. So this is the framework I want to talk about, and then this is the framework for one individual, right? And then what we have is a population. This is just many people. It's 4 because I couldn't make my arrows fit. And the key idea here is that these people are related to each other. They're all human beings, right? With the same sort of biology. Not identical biology, but related to each other. I was an expert when I was a younger person for the states and the federal government when they sued the tobacco industry in America. And I had a friend who was, I was a statistical expert, and my friend was the medical expert, and he testified in Minnesota about lung cancer and so forth, and the tobacco industry lawyers sort of hammered on him that he really didn't know much about the state of Minnesota, and he assured them that getting a medical degree at California, where he had been trained, enabled him to practice medicine in the state of Minnesota, and that people were different in Minnesota, but not that different. Anyway. So this is just basically saying that there's a hierarchy here and that we can learn from other people about a particular... That's what we did with that screening problem. So this is a framework that enables us to do that screening problem, and now we can maybe do this with more complicated kinds of data. So I'm not going to take you through all this, but each of the questions we ask, what is a person's health state given their health measurements to a particular date? So that's really asking, what's eta for Joe's person I, at time t, right? What is eta? And you can see from this network that the answer to that question depends upon Joe's measurements, but it also depends upon what we can learn from the rest of the system. This is the way in which we can individualize care, right? Individualize predictions using a network of a population of people that are otherwise similar. So each of the questions I'm interested in can be framed in this way. And the problems get more complex. The first question is, how can we predict a person's state of health at this moment? And then how can we predict their trajectory? And then how can we predict what's going to happen on average if we give a particular intervention and so forth? So there's a hierarchy, and I'm going to start with the simple problems first. So let me close. I'm doing pretty well on time. I have yeah. I'm going to just give you 2 very quick examples of of applying that model to real problems. So the first one is a project funded by the Gates Foundation in the United States, and the purpose of this, well, pneumonia is the leading cause of child death in the world, under 5 child death in the world. Number 1, diarrheal disease is number 2, and this study was intended to understand which of the pathogens cause death. So pneumonia is just the word for a clinical condition, fever, cough, etc. That's called pneumonia, but pneumonia is caused by an infection in the lung, and there are many things that can infect the lung. And what you would do to treat a child or to prevent pneumonia globally would depend on which of the pathogens are most important. This study is intended to find out, and so these are some of the kids in our study, and the interesting thing, this is a perfect example of what I'm talking about, because what we want to know, eta, in my model, is the infection in the lung. But you can't find out what's in a child's lung. It's not available to you. They thought when they did this study they'd be able to put needles into some children's lungs and take samples, and it turned out that wasn't a good idea. And but so they don't measure the lung, right? They don't measure the lung. So what do? They culture the blood. They PCR the blood, they culture the nose, they PCR the nose, they culture the sputum, they take modern measurement technology and they apply it to peripheral samples. But the question is, what's in the lung? So it's exactly what I was describing for you. And we have 5,000 cases and 5,000 controls, matched controls, and I'm going to just show you data from 2 sources, from the nasal pharyngeal cavity, where we have PCR for 30 different pathogens, and from the blood cultures, where we can only culture bacteria, we can't culture viruses. So here's the analog of that model. The thing we want to know, I call it eta, but because it's an infection, and I work with doctors that couldn't take eta, so it's now called infection. This is the lung. That's the measurements we have. We have a lot of information about how these measurements reflect what's in the lung from other sources. So we have prior information about the measurement errors here. I'm not going to spend much time. And the question is, how do certain covariates cause the infections, and most importantly, which infections are there most common. And we have data on lots of people, so we're going to nest each child within the population. So I'm going to skip over the details of the model, but let me just say that the controls enable us to estimate false positive rates. In the cases, when we have a child who's a case, these are the controls. These are all the false positive rates. If you measure in the periphery a pathogen for a control, it's a false positive, right? They don't have anything in their lung. Controls don't have anything in their lung. Cases have something in their lung, and if there were 5 possible things, 1, 2, 3, 4, 5, if there were 5 pathogens, what we would be observing is a mixture of a distribution across the 5 different pathogens. And what we want to know is the mixing probability, what we call the population etiology pi, the etiology pi. And the software that does this is called Baker because it makes pies. I like that too. Bayesian something. So if this child is infected with pathogen A, and the probability of observing A in the periphery is a true positive rate, but the probability of observing anything else there is a false positive rate. And so this is the mixture. We want to estimate these pathogen pies, and we can estimate all the false positive rates from the controls, and we have to estimate the true positive rates. And we have some prior information about that. So I'm not going to take you through the details. I'm just going to say that what you get out the other end is a picture like this that has the posterior probability that a child is, that a random child, without looking at the data, this is sort of the population pie. We estimate that 27% of the infections are caused by a virus, RSV-AB, 27% by bacteria, pneumococcus, and so forth. So we get posterior estimates of the prevalence of these things, and this is all the data, which we won't worry about. And you can ask questions about functions. For example, what's the probability that a child is infected by a virus as opposed to by a bacteria? And so we estimate for this particular population about 60-some% of the disease is caused by viruses. So that's the population, but we can also now make statements about a child. So if a child had, these are the 10 most common or 11 most common pathogens, and unfortunately this didn't show. This says, I think, Haemophilus influenza, and over here is RSV. This is a child who had a positive for Haemophilus influenza and a positive for RSV in their nose. In fact, 11% of the kids had that pattern. And we estimate with 100% uncertainty by one of 2 different models we were using that it's RSV. We ignore the Haemophilus finding and we say it's RSV. And that's because we know a lot about the population and we know a lot about the measures from having 5,000 cases and 5,000 controls. And so these are the most common patterns that we see. And you can see if you have Haemophilus influenza in your nose and nothing else, we just don't know what it is, basically. And so what we give is the posterior probabilities, basically. I mean, the prior probabilities, the prevalences. And you can see if you have RSV any place, we know it. If you have paraflu, we're pretty certain. And so you can now diagnose individual children. It's an example of using population data and complex data, lots of data in the periphery to be able to say what we think is in the lung. Okay, so I think we have 5 more minutes. Let me give one more quick example. So here's going back to that lethal disease. This is prostate cancer. It turns out that if you detect prostate cancer in a man fairly early, about half of those people, half the men who are detected reasonably early, have a form of prostate cancer that is indolent. That is to say, it will never cause them any harm. And the best treatment is to do nothing, because if you remove the prostate or you radiate the prostate, there's a high fraction of people are incontinent, have to wear a diaper the rest of it, or impotent, and have many other serious side effects. So the treatments are good if that's a lethal tumor, that you want them, but if it's not a lethal tumor, you don't. So the question is, it's just like we had before, you can't know whether that tumor is lethal or not. We can do biopsies, but the biopsies only get about 0.5% of the tissue, and you really can't be certain by it. So that's the problem. It's exactly like I described. The unknown thing we want to know is the true state, latent state of the cancer, and we observe biomarkers called prostate-specific antigen over time. This is a measure that if you have a score of 4 or above, you should be worried a little bit. And these men all come in with that score, and we have those measurements. We also have biopsy results, and we also think that maybe the fact that men are getting biopsies a lot might be informative. And ultimately, for a subset, there's a surgical removal, and we wonder whether that might also be related to the true state. So that's the formulation. Here's what the data look like for a man. So this is PSA scores. Remember I said 4 is the threshold. And this particular man was getting them almost every year, and he was up around 10 and fluctuating around. That's a high level of PSA. And down here I'm showing as a function of his age, he had biopsies at each of these times. And the biopsy results were equivocal for this man. That's why they're plotted down here. Sometimes they hit tissue that they are certain is a lethal tumor, and it would then be plotted up here. So the data are repeated biopsies and repeated PSAs. Again, more complex than just that binary indication of the screening test. And the question is, can we take these data and now say something about the thing we don't know, which is the lethality of the tumor that we're trying to observe. So we have data at Johns Hopkins for this man, but we also have 1,300 other men on whom we have data, and for about 700 of them, we followed them forward, and we know what, we ended up taking out the prostate. We know exactly what the tumor was, because the pathology we can do with the whole prostate is unequivocal. It's observing that underlying unknown state when the man first shows up. So we can use that data to train up the method, and I'll just take you through to give you an idea of what we get out the other end. So here's one man who had PSA scores increasing. The method predicts where we think that's headed. He had 3 biopsies that were equivocal, never had a positive one. He passed up having these 3 biopsies. This means he could have had them but didn't have them. And this is a prediction of where what his probability of getting a positive biopsy would be if he would have another one, and we think it's all the way up to 50%, and we think he has a 39% chance of having an aggressive tumor, a potentially lethal tumor. So we can now give those data, and let me just see if I have, yeah. So here's a bunch of different men, and you can see here's somebody who has PSAs that are down closer to about 2, had lots of negative biopsies. We say it's only about a 3% chance of having a lethal tumor. And the point is, this can inform the decision that's made by the patient and the doctor. Okay. Just a quick advertisement. We got a grant to try to mimic what they did with Bioconductor, to take all the people who are doing stratified medicine who have software, and the same people who helped to build the Bioconductor team, in particular Vince Carey is leading a group of them, and they're going to create an environment where you can post your data, post your packages, and we'll be able to build software of many kinds that will enable us to try to individualize care. So let me just close with the main ideas once again. What I've hoped to argue is that individualized health really, as you say here, means stratified medicine, and you can't stratify without a population. So individualized and population health are really 2 sides of the same coin. The low-hanging fruit that we don't do well with yet, but we could do well quickly, is in measuring a man's health or a person's health state and their trajectory. That these sorts of graphical models that I've described allow you to integrate multiple sources of data and prior medical knowledge and to make more formal what clinicians tend to do informally. They can't do it well informally as the data becomes ever more complex. And the question is, can we actually improve patient and health outcomes at more affordable costs by bringing data science together with biomedical science to be able to improve healthcare? Thank you very much.
Okay, the floor is open for questions. We have roving mics. Please do wait for the mic, because although you can all hear me, we can't necessarily hear all of you. Any questions? Jane Hutton.
Jane Hutton, University of Warwick. I was interested in your screening example because I have a PhD, part-time PhD student struggling away with breast cancer data, trying to estimate things which, in fact, they're not even defined. And that's not her fault. That's the entire screening history. It strikes me that one of the other low-hanging fruit you would have is stopping as much screening. Surely that's one of your main drivers of costs.
It's a great, very insightful, Jane. When we first started this project, the first those two things I showed you were so-called pilot studies. The first pilot study we attempted to do was to do so-called individualized cancer screening. We took the 5 leading cancers. We had a research group on each of them. We sent them off to figure out, from simple measurements you can make on people, whether somebody should be screened for that or not. And that was a total failure. And it was a total failure because in my health system, the data that you would need to be able to build those algorithms is simply not available. And we thought it would be available. We had a lot of buy-in from senior leadership, but we just don't have the data in our health system on the patients that we couldn't build the system. So we could do it in these specialized areas where people have good data records that are separate from our health system. Even though we spend all that money, we do not have an integrated health system that has consistent data, even within a single hospital, let alone across the country. So we're primitive, and we couldn't do it.
While you're thinking, I'd like to make a comment which may turn into a question. Peter McCulloch has a contribution in the RSS journals in the discussion of one of the red papers that the honest answer to any prediction problem is a probability distribution. And the way you presented your results suggests, unsurprisingly, you would agree with that. How do you communicate that to the clinicians?
Well, that's a very a good question. And a former question is, to whom do you communicate it? Do you communicate it to the physician, or do you communicate it to the patient directly, or do you communicate it to them together? And we actually have a small grant to bring groups of clinicians and patients together to bring in 3 areas: in depression, in prostate cancer, and in that pneumonia example, to ask, what's the most effective way to communicate this information? Of course, the probability distribution of the state of health or the trajectory is former to a loss function, and that's necessary for decisions. And then the question is, how do you have a conversation so that qualitatively a patient can express their preferences about the choices before them and then reach a decision? It's an open question. There's a lot of people work on that, and I'm just starting to get educated about it. But certainly, we have built shiny apps for these things so that we can play with them internally, and our clinician friends play with them and give us feedback. But we wouldn't. I don't think we would ever make those public to like patients until such time as we had a sense they had utility. And one thing I would say is that in a really the right thing to do is to take these tools, and there are many of them around, and to do clinical trials with them, not to treat them as if they're somehow better, but to actually subject them to a clinical trial evaluation. And we're trying to convince our leadership of the health system that has to be sort of routine business. You get better tools for using information, you demonstrate that they're effective within your own health system, and then you can try to share them with other people and hopefully move them out to broader use.
Back to the room.
Hi there. That was great. Really enjoyed it. But one of the things that worries me about prediction models often is generalizability, particularly when we're getting into reasonably sophisticated ones like this. So, for instance, on the pneumonia example, I would have thought the background distribution of pathogens and maybe what you detect in your controls, for instance, would vary quite a bit across time, across space, and so on. I wonder if you could comment on how we deal with that and how we do kind of continual recalibration of these models.
Yeah, it's an important point. So that study is done in 7 locations on 5 continents, and we estimate pathogen pies separately at each place. and we have cases and controls at each location, and we've done it across a 2-year period, and we actually estimate the pi and how it varies smoothly in calendar time. 2 of those pathogens, rhinovirus and RSV virus, are highly seasonal. They tend to be a little bit out of phase in their season. So with models like this, you learn a little bit about what's the basic epidemiology, and then you do need to when you are first. Let me just say one thing before I go on. That what's the alternative, right? The alternative is, medical doctors were put in the situation to go like this, most of the time. They have all this information. They have some judgment. You can hold 4 or 5 things in your head and then do the best you can. But there's increasing amounts of information. So even with not optimally calibrated models, you have to say what's the clinical alternative, and it's a model that goes like this. So you want to demonstrate that however it's calibrated model beats the intuition or not. But going back to your point, so it's an open and important question in all of data science to have a prediction model that has parameters that change smoothly, and the most important aspect of that is for a model to come to understand that it's not doing a good job and to sort of suppress itself until such time as it can learn to get better. And I had a guy come to my office last week with a problem. He described this thing he said looks like a sort of a torpedo with wings, and it travels around the North Atlantic, sending back data. I have no idea who he worked for or anything, but sending back data and predicting a lot about the traffic of ships and other things in the ocean. And it works great in the North Atlantic, but as soon as it gets below a certain place, it doesn't work very well. And he was really asking questions about how do we get the intelligence to realize it doesn't work very well when it doesn't, and to somehow suppress itself. So that's an open question in machine learning, and there's a lot of interesting work going on in that space, and we're going to eventually have to learn. But I take your point. These models are going to work well sometimes, but not work well other times. We've got to make sure we know which is true.
Deborah Ashby.
Thank you. That was great. Really more a comment than a question. I'm sure the way to go on the communication is
We can hear you clearly.
the way to go is visualization. We've done quite a lot of work with a big European project on benefit-based decision making for drug regulation, and actually work with patient groups, not so much patients, but some of the charities and so on. And there's all sorts of prototypes around that. Absolutely right, they need to be tested out. But the huge question it raises is the availability of data on our treatments, the availability of trial data, but the kind of thing you're talking about. As you say, you haven't got the data in the States. We've got it in this country, but getting access to it, people's right to withdraw, and it's that interdependency. For me to have my rights, whatever you call them, to a personalised healthcare, what I need is everybody else's data to benchmark against, and I think, another hat, the RSS involved in that, but absolutely key, because otherwise, with all the beautiful modelling in the world, that was really beautiful, without the data, but when we've got it, we still can't access it.
Yeah, I hear you, that's sort of we also have the data, but we can't get our hands on it, and it's in the United States, it's mostly owned by the business people because they have the data to get themselves paid and not to do science. One thing that's happening, I've gotten to know a little bit about bioethics. I know you know a lot about bioethics, but I didn't know much about it. But there is a movement, a very exciting movement among bioethicists. This notion of separating research from care. There's this sort of bright line that really came out of the experimentation, human experimentation that was inappropriately done, 50 to 60 years ago. That bright line is a real impediment to improving healthcare, and the bioethicists are now talking about the unethical behavior of a system not learning from its previous care, and they're framing ignoring this data as being unethical behavior, and it's going to be changing the debate. I've been at some of the meetings where they sort of have each other on, and I would say that the people who are moving towards a so-called learning health system where you actually use this data. Everybody is consented. When you get the care, you consent that you acknowledge that the previous patients are benefiting you. You are willing for your data to benefit the ones who come after you. And that model is going to win the day. It may take a while.
Yeah, before I take the next question, unless he cancels on us, which apparently has probability much more than 0.5, Jeremy Hunt's agreed to see a delegation with the Society in a couple of weeks' time. And the first item on our agenda is data sharing and open data and appropriate balance between privacy and public good. Question near the back of the room.
Marcus Elzel, London School of Hygiene and Tropical Medicine. So I'm wondering a little bit about your figure of the $1 trillion and sort of how much harm comes from that. Because I suspect, because it's sort of, as I understand, mainly a private healthcare system, it's sort of private individuals paying for treatments that may not necessarily be very beneficial. So in some sense, they feel like something ought to be done to make themselves feel better, and that thing is done. So could you elaborate a little bit more sort of on what the damages are from that, aside from the fact, of course, that it's quite unethical to apply potentially harmful treatments that, to patients that don't need them?
So yeah, you know, I'm not an economist, and I've made this statement several times, and usually the economists get up and say this is just a form of economic stimulation. What's the difference if we spend $3 trillion a year, $1.5 trillion of which is not producing anything of any value? What's the difference if we do that? I think of it as like, you know, just stimulating the economy. If people are getting paid, they're spending money. You know, it's sort of a, you know, generates an economy. So, you know, I'm not an economist. I would feel okay with that, actually, if the bridge near my house didn't fall down. You know, it's like, you know, and when someone says, gee, the bridge fell down, and well, yeah, okay, yeah, sorry. And the federal government says, well, you know, we're not going to have money for that. We don't have any money for bridges. You know, or when New Orleans gets, you know, swept away and horrible, and they basically leave them out to hang out to dry. If they were investing in the other stuff and they could spend $1.5 trillion, I would accept the argument that it was just stimulus. But they don't invest the other stuff, and they say they don't have any money to invest in it. So I'm saying, you know, here's some money. Here's some money. Let's somehow capture this money. Now I know that's unrealistic. And I'm not an economist, and I know these are cheap arguments. But you know, there it is. You saw the graph. You know, you could say it's okay for America to do that, but I can tell you that they're not investing in infrastructure, and that it seems to me that it's wasted opportunity. There's an opportunity cost, and it does do people harm. There's actually that money goes to two main places. One is that we pay medical doctors a lot more than you pay medical doctors. You pay them very nicely. We pay them even more nicely. And they're all small businessmen. And the reason we can't have, and women, we can't have these discussions is because when you get in the room with a bunch of clinicians, they want to take care of their patients, but they are business people, small business people. And if you try to take some of their money away from them, they're very politically active.
I'm grateful to Scott for reminding us that statistics was originally statistics and is political in its origins, and there's a political dimension to data science. Any more questions? We have time for one more if anyone wants to have a go. Jane, you've had your turn. Anybody else? Yes, thank you. Catherine Riley.
Hello, I'm Catherine Riley from Imperial College. Thank you very much for a really interesting talk. It was really enlightening on stratified medicine. So aspects of sort of latent variable analysis, it's quite nice to see that applied to stratified medicine. I'm just wondering if there are other statistical techniques that we should be thinking about when seeing problems in relation to stratified medicine. Certainly in the UK, I think there's quite a lot of interest in different methodological techniques. Yeah,
so this is really, I tried to give a general framework, but if you now ask, what are the open and most pressing questions? Certainly, if you start where we do experimentation, there are very important questions about how to design clinical trials and how to analyze the results from those trials to be able to say more than the treatment works or it doesn't work. And you know, there was a session here today about those kinds of things, and there's lots of very active research where you design adaptive trials with pre-specified subgroups that you drop along the way if they don't look like they're going in a fruitful way, or at the end of and having done that at the end of the trial, to be able to declare that the treatment is efficacious in a particular subgroup and be neutral around the rest, or be able to say it's not efficacious. So there are various combinations, and there's some interesting work in my own department by Michael Rosenblum and others, sort of causal inference methods for subsetted trials. And then at the other end of the trial, there's the hypothesis generating analyses that say, here's the trial result, here are a whole bunch of subgroups that we would have expected some to have benefited more than others, and then I try to identify covariates that interact with the treatment to be able to then tee up the next design, which focuses on those subsets. So those are interesting and important questions. The other area where important work is going on is more towards the airplane model. Obviously, if we can identify the underlying mechanisms that indicate whether a person will benefit from a treatment or not, so-called pharmacogenetics. And everybody's focusing on genetics because that data was available, and everybody thought, that's going to be the difference maker, and that's the... I think if we could be a little bit broader than just genetics, and to try to identify the mechanisms by which the treatments, some treatments will benefit a subset of people, like that ARV7 example I had. You have a mechanism for a drug. You should be able to. You should try to use the current science to be able to identify potential structural subgroups or other sorts of subgroups that would indicate where the treatment will be efficacious or not. This was actually, I used to be on a scientific advisory board for a leading pharmaceutical company 15 years ago. And when you would bring up the possibility that was the direction they should go, and they would shut that conversation down in a millisecond, because their game was to get something approved and then to have everybody use it. Now that they can't get things approved so easily, they're much more interested in finding subgroups in which the treatment is efficacious, and there's much more basic science around the mechanisms of the disease. So that's a good thing, and that's another big area of statistical research, because ultimately you're looking at high dimensional spaces for indicators of efficacy and safety.